Good evening, ladies. Y'all know I'm Angie, and I'll be presenting my PowerPoint on postpartum hemorrhage today. To start off, we're gonna start with a definition of postpartum hemorrhage. Postpartum hemorrhage is usually defined as for vag delivery, it's 500 cc's. And for C-section delivery, it's a 1,000 milliliters of blood loss. Postpartum hemorrhage is a life-threatening complication of childbirth, the most significant cause of maternal death worldwide. Of the 50% maternal deaths that occur within 24 hours of delivery, postpartum hemorrhage is the most common cause. Some of the classifications of postpartum hemorrhage would be primary. Some of the common cause of hemorrhage in primary hemorrhage is uterine atony, a retained placenta, and lacerations. Secondary hemorrhage, which occurs 24 hours to 12 weeks after delivery, and some of its common causes are the sub-involution of the uterus, retained placenta, infection. I'm going to talk about uterine atony and define what it is. Uterine atony is where the muscles of the uterus do not contract after delivery. And one of the main causes would be a full bladder. We see a lot of that where the bladder's deviated to one side, but it's a full bladder. Also, excessive manipulation of the uterus, prolonged labor, and having multiple pregnancies. Retained placenta, this is where the placental fragments of the placenta may adhere to the uterine walls, therefore preventing the uterus to contract. This is caused by manual removal of the placenta, and placenta accretion, which is where the growth of the placenta into the muscles of the uterus. Lacerations are what we see a whole lot of. These are tears of the perineal tissues occurring during childbirth in the labia, perineum, the uterus, the cervix, or the vagina. Some of the common cause of lacerations would be precipitous delivery and delivery of a large infant. Preventing hemorrhage. Preventing hemorrhage start with a careful assessment immediately after delivery, and this is the best way to prevent hemorrhage. If bleeding does occur, you might want to be able you'll be able to quickly to respond to any quickly respond and to go ahead and initiate your facility's protocol. You first want to, this is normally done by the doctor or the midwife, do a quick assessment of the placenta, make sure you don't have any missing pieces or parts, check the cervix and the vagina and the perineum. This here is an example of my hemorrhaging patient, which some of her signs and symptoms, she'll start complaining that or you can see that her skin is very pale, even her lips. Her blood pressure is really low, for example, 86/52. She'll start stating that she feel really weak, and she feel the trickling or some bleeding, and feeling wet. Her respirations are usually elevated also, for example, maybe 24 or greater. Heart rates are elevated also, which is could be up to like 138 beats per minute. But also want to always check her SAT, which is in this hemorrhaging patient would be like at a 90% or less. Some of the management of postpartum hemorrhage is medication, which we normally do is Pitocin. Pitocin we usually give IV in 10 to 40 units. We do a 20 units in normal saline or LR or lactator ringers. This is done IV and has an immediate onset. We also give Methergine, which is given in an IM form. This is given every 2 to 4 hours after delivery. This here you don't want to give to any patients that are hypertensive. Through recent research, they found that the Cytotec, which is a 1 dose only, is the choice of medication to give to postpartum hemorrhage, during postpartum hemorrhage. Onset is 3 to 4 minutes, and it's a one-time deal. According to the World Health Organization, the active management of third stage of labor is the optimal timing of umbilical cord clamping, early skin-to-skin contact between mother and newborn, and early breastfeed initiation are safe, effective, feasible, and evidence-based care practices that should be offered by a skilled birth attendant to all mothers and their infant in the continuum of maternal, newborn, and neonatal care. To initiate this active management of third stage of labor, we start by giving the urotonic drug, which is the Pitocin. These are our drugs of choice: the Pitocin, Methergine, and the Cytotex. You want to delay that clamping up and cutting of the umbilical cord following delivery of the placenta by the control cord. And when you want to go ahead and start uterine massage right after delivery. And you want to do this every 15 minutes for the first 2 hours after delivery. To conclude my presentation here, we can all be more proactive in our day-to-day dealing with new mothers. And as they're being discharged from our facility, by teaching them to notify the physician when bleeding increases and she's soaking her pad in 30 minutes or less, or passing clots that are quart size or greater. Thank you for being willing participants. Do you have any questions, concerns?
No.
Well, thank you, ladies.
Thank you.